All right. So this is Andrew Dombek and my unnamed podcast now. AID Performance Physical Therapy is my business. I'm a physical therapist. And today I have I can't think of the word I just dropped. the distinguished pleasure of having super doctor, Dr. Robin West on. Thank you for coming on. You are so busy. How do you manage your insane schedule? Thank you for coming on. Tell me a little bit about yourself, your background.
So thanks for having me, Andrew. It's great to be part of this. How do I manage my schedule? Well, I am busy. I'm an orthopedic surgeon, and I am the president of the musculoskeletal program, the service line for Inova, which is a large healthcare system in Virginia. We oversee 5 hospitals and 5 ambulatory surgery centers and all the outpatient clinics. So it's busy. I also am the head team physician for the Washington Nationals, and I was an NFL team physician for 18 years. So it's busy, and I'm a mom. And but you know what? The best way to manage it is to have great partners, have great people to work with, and that makes it really doable, right? So that's how it all works.
Okay. Now, one of the big things I know when I did some research is we'll get to this later. I have other questions about collaborative care, but you skipped that you're also a triathlete. Like how do you have time to train for that as well?
I am a triathlete. You know, I've had some actually had a major surgery recently, so I'm not training right now, but I like to squeeze it in. I'm an early bird, which is good. That's helpful. So before anyone wakes up, I always like to get things done. My husband laughs on the weekends. I get up at 4 or 5 in the morning, and he's like, "Why are you up so early?" But I don't like to miss time with my family, so I try and do it when everyone's sleeping.
That's good. So you mentioned 18 years. What happened? You're no longer with the Washington football team. Wasn't that one of the reasons you came down here, or was the big job of overseeing all these hospitals the reason for coming down here?
Yeah, the job was actually what enticed me. I was in the University of Pittsburgh. I was at UPMC, and in Pittsburgh for 12 years, and I took care of the University of Pittsburgh teams there. I took care of Carnegie Mellon, and I was also the team physician for the Pittsburgh Steelers. So I had a great job. I was not looking to leave. It's a great sports town, as I'm sure you know. But Inova reached out to me, and they were looking to build their sports medicine program. There was really nothing like it to build a comprehensive program in the area. And so it was an opportunity where I could come and do something that I really believed in. Like we talk about comprehensive care and building something from the ground up. And so that was my opportunity to come here. And so when I came here is when the other opportunities came available, as far as taking care of the teams and Washington football team and also the Washington Nationals. But we also take care of the Washington Spirit, and we take care of a lot of club teams in the area as well.
Yeah, I think I mentioned to you that one of my future guests will be the head coach for the Spirit. Richie Burke is going to be coming on.
He's a great guy.
Yeah, I love him, and he and my daughter have a great bond. He's, Dr. West. How I met her was she was a surgeon that operated on my daughter. She did her ACL. I'm very grateful for that, and so Richie has been sending her kind of inspirational text messages.
Oh, that's great.
But getting back, what was it like being a female in such a male-dominated sport or profession? Well, the profession of orthopedic surgeons, not to mention being one of, I think it was like 6 or 8. I know at one point you were very few to be part of 2 major league sports doctors.
Yeah. So, in orthopedics, it's when I first started, it was like 4% women, and now it's 6% women in orthopedics, and in sports medicine, it's less. So I started off in a profession of mostly a male-dominated profession, and then obviously in the NFL, there were only 2 of us as orthopedic surgeons in the NFL for a long time, and then I was the first head team physician female in the MLB. So I never really thought about myself as differently. My mom raised me. She was a single mom, and she worked in a male-dominated field herself, and she raised me to believe that I can do anything, and really never to take my gender into account, just to do good work. And she said, you'll probably have to work harder than a man does and prove yourself more, but you just do it, just do what you can do. And so I never really thought about it, honestly. And I can't say that I've been really treated differently for it. I mean, sure there are certain things that men don't have to experience that I had to experience. I mean, there are no women's locker rooms and no women's bathrooms and these, so trying to figure out how you're going to change into your game day clothes and all these things. I was pregnant on the sideline. I had my daughter. I had a week after I was on the sideline for football games. So I had to, I nursed my kids and had to pump milk and all this stuff that men don't have to deal with. But I had to figure out how to make that work as I'm taking care of teams and traveling with them and going to the Super Bowl. And so that makes it a little different. Just think outside the box.
So 18 years in the NFL. How are you going to spend your Sundays this fall?
I'm actually going to probably go to some games, go to some and be a fan. I'm going to be a fan of my kids' games. My kids are very active in sports, so I get to go see them in the fall, which is awesome. And I'm going to actually probably go to some games and get to tailgate and see my friends.
There we go.
My husband's happy because I'll have some more time around the holidays too.
Yeah. You won't a lot less travel. How much time are you spending now with the Nats compared to, because there's so many games with the Nats compared to NFL? There's just, 16 regular season games and who knows how many. We didn't have any preseason games last year.
Yeah. So we have a lot of games, 81 home games. And so we have to provide coverage for every game. Luckily, I have some great partners who help out. So one of us is at every game. And so we cover all the home games. And then as we get into playoffs, we'll travel for the playoffs. So it's busy, I mean, when they're home and they have a, 10-day homestand or something like that, we're here and working hard. It's different injuries though, right? Baseball is a lot of overuse injuries, injury prevention. So we talk about working with our team. We've got some great athletic trainers and physical therapists, strength and conditioning coaches, and we're all part of the team. And those guys play a big role in it.
Yeah, the collaborative care that you kind of elaborated or intimated on, and also talking with baseball with those players. Tell me more about the collaborative care. What does that mean to you? And
yeah, I'm a big believer, and I've always I played sports my whole life growing up, and I always believed in that team approach. I did my fellowship at the University of Pittsburgh, and I remember talking to Dr. Fu. He's Dr. Freddie Fu is one of the most famous orthopedic surgeons, and he was a chairman there. And he really taught me about that team care and saying, hey, listen, you're like a little tiny part of the team. The players are the part, right? But everyone else plays a role, and your little part is, you'll do a surgery on someone, but it's the injury prevention, it's the performance side, and it's the recovery and how do you work together. And so that fellowship really taught me about how that whole team works and how to make a successful medical team. So that's where I really started thinking more about it and really believing in it. And then when I came here, that was my goal, to come here and to build something collaborative where we could all work together, where it's a one-stop shop for athletes and families. You come in and you can work with our athletic trainers, our physical therapists, our strength and conditioning coaches, nutritionists, sports psychologists. It's all, as you know, Andrew, with your daughter, it's not just one little thing, right? People say, oh, you did a great surgery. Okay, my part was like an hour. You're the patient has to they have a lot of recovery to do ahead of them, and having a team is key.
I really appreciate you saying that, because it's oftentimes one of the gripes that I have as a physical therapist is you see, like, my daughter was a big fan of Alex Morgan, and she read her biography, and she talks about what a great job the surgeon did. And I'm like, well, the surgeon, like you just said, spent an hour doing the surgery. What about, she mentioned, yada, 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 physical therapy. Now I'm back on the field, but I'm like, they spent, countless hours with her on top of the personal trainers and stuff like that. At some point with this collaborative care, someone has to step up and make an important decision. How do you differentiate? All right, this is going to be my call. I'm assuming you're taking everyone's input, but at what point that's got to come up as a scenario similar to, let's say, Alex Smith, who makes a call on, all right, we're going to keep his leg or we're going to amputate.
Yeah, it's tough. It's collaborative, like you talked about. I mean, ultimately on the team side, the physician has to clear the player to play, right? So after an injury or a surgery, so we have to give a medical clearance to do that. But that's never taken lightly. I can tell you, Andrew, I don't just make that on my own. I mean, that's something that I talk to the physical therapist. I'll talk to everybody, strength and conditioning coaches, and say, hey, what do you guys think? And if we're all in agreement, then I'm good with the decision. If people have concerns about somebody being weak or not ready, then I'm not going to clear them.
So talking about clearing them and, injuries are part of the game, and there's a physical and a mental aspect for that. Where are you as far as the mental aspect with dealing with some of these people that say, hey, someone needs a kick in the butt? Like, whose role is that? Is that your role? Do you, where is that? I mean, if you're part of the team versus, your independent practice.
Yeah, that's a good point, Andrew. I saw a girl yesterday in my office. I did her ACL a couple of weeks ago, and she does not look good at all. She's working with a good therapist. I know her therapist well, but she doesn't look good. So I talked to her and I said, listen, you have to take responsibility. She's not taking responsibility for her care. So I've got to give her a kick in the butt, right? And also I talked to her therapist and said, you have to push her because he's a nice guy and he's being a little gentle with her. So it is a combination of us trying to motivate the athlete because they have to take the responsibility. As you know, I mean, you're treating patients too, right? Some patients are very engaged and want to get better, and others are kind of taking it passively. They need to be actively engaged in their rehab.
Yeah, I think I watched some video clips, I think from ESPN commentator Ryan Clark, who I think you worked with in ES on with the Steelers, and you mentioned, or he mentioned that, or you mentioned at some point that they came to you or trusted you more because you were a female. Can you elaborate more on that as far as the relationship and being able to trust you because you're the doctor and you work for the team, you don't work for the player?
Yeah, so I think a couple of things. I think working for the team versus working for the player. My role is always for the player. So we're independent, really. I mean, the team will pay us a consulting fee or something. I sign us as a consultant. So we're not really necessarily working for the team. We're providing a coverage, but the goal is the number one person is a player. So always have to keep that in mind. It's not about winning the game. It's not about anything else. It's about getting that player well. And if you have healthy players, you're going to win games. So that's the number one thing. Being a female, people have always asked me, like, in the NFL, saying, oh yeah, has it been hard being a female in the NFL, and do the players trust you as a female? And I've always found the opposite, and I don't know why that is, but I think that a lot of the athletes have been raised by strong mothers or grandmothers, and so they actually view that the woman as a provider of their family. And so maybe that's why. I don't really know, and I've tried to ask some players, and that's what I've heard, and so I'll take it.
So what is your stance on as far as the importance of physical therapy, let's say before or after, outcomes based, like before or after surgeries? What's your stance on that?
Yeah, I think for some things it's really important. And the same thing with your daughter, if somebody tears their ACL and they have a big knee effusion and their range of motion is poor, coming into surgery like that is going to really set them back. You want them to come into surgery with good motion, limited swelling, good strength, because it's going to help augment their recovery after surgery. So I'm a big believer in that quote unquote prehab for certain things. Some things not as much, right? I mean, somebody has an acute rotator cuff tear, they're falling, they slip on the ice, tear their rotator cuff. You should fix it. I mean, we shouldn't delay and poke around and work on strengthening. They're not going to have their strength. They have a massive rotator cuff tear from a fall. So those are people I'm not going to prehab. They're people we're going to fix and then get them recovered.
How has COVID impacted your practice? Has there been more surgeries this year because of the lack of preparation of the teams or strength and conditioning or the compactness of the schedule? What have you seen?
Yeah, it was, with COVID, we initially cut back our surgeries and didn't see as many things, right? Because everyone's quarantining. Those first couple months, very, very quiet. People are postponing surgeries, and then we're not seeing the athletes. They aren't out practicing. But then, Andrew, it came sometime in the fall. It was interesting. I came into clinic to start seeing my patients, and my first 3 patients had ACL tears, and they were back-to-back ACL tears, and they're teenage boys who've been playing lacrosse. And I'm like, this is weird. Just 1, 2, 3, and I asked them all, and they all had started practice the week before. It was lacrosse practice started, and they all tore their ACL on the first day of practice. And so that kind of hit me hard. Like, wow, these kids, these are pretty high-level athletes or high school lacrosse players looking to play in college, and now here they are tearing their ACL in the first game first day of practice. So clearly, by being inactive for those first 6 months and not being out and conditioning had a big effect. And I've continued to see that. I've continued to see a pretty high rate of injuries as sports are getting back into play.
Yeah, I think I've sent you probably half a dozen athletes just from one football team that, and I think I was telling my staff, I said, unfortunately, we're going to see a lot of injuries. There just wasn't enough buildup for, especially with a sport like football.
Yeah.
I know on just one team alone, 2 meniscus tears, a shoulder dislocation, ACL tear, a traumatic ankle dislocation, and a couple other knee strains and stuff like that. It was just, it was devastating to the team.
It's devastating. And a lot of them are non-contact, right? That they're not contact from football. I mean, they're typically non-contact injuries.
Now, what is your stance now? There's probably 2 more games in the football season. So we're going to go into the beginning of May. I think May 4th is the end of Virginia high school football. August 1st, football practice starts up again.
Yeah.
For a youth athlete, is that enough time for them to recover, to gain strength, and to be ready for an entire football season, not just an abbreviated season, but an entire preseason plus, 10 games plus, 6 playoff games if you make it to the championship, I think.
Yeah, I hadn't thought about that. I mean, that's certainly concerning, Andrew, and this season was kind of squeezed in, right, pretty tight, right? So, like you said, they came in not conditioned, then they played, and now they're getting out of it, they need some time to recover from your season, especially a contact sport like football. So that is a concern. I think we have to really address with these kids that they have to recover, spend a little time recovering, and then really focusing on getting back and strength and conditioning before the season. A lot of kids will take the summer off, right? When they're playing football, and they'll come in to training camp, not as conditioned, use training camp to get their conditioning back up. And they're young, they can do it quickly. But I think you kind of push, hey, we've got to start conditioning a little earlier than just training camp.
Football is probably one of the most violent sports out there. And they talk about, especially, I don't think I've been on a college football sideline, but I've never been on an NFL football sideline. And they say, the tackles, the impacts are like, car crashes going in 25 to 30 miles per hour. Now you got these injuries, but also some of these guys don't necessarily get injured, but they're banged up. How are you managing their pain these days?
Yeah. So, pain management is a big thing for everything, for these kind of contact athletes, for surgery. I am a big believer in using kind of a holistic approach. So, managing it without narcotics, right? And trying to figure out, even without anti-inflammatories, because anti-inflammatories have a lot of dangers too. So how can we help people? And there are all kinds of holistic things you can use, as far as fish oil, anti-inflammatory, using turmeric. So more for chronic pain and chronic or recovery. Tart cherry juice is another thing. So using a tart cherry juice, we know that it helps with sleep. It's got high melatonin levels in it. It's got natural anti-inflammatory properties. So during a season, recommending these types of things, green tea. And so I try and take that approach. And then we also, obviously, on the recovery side, looking at physical therapy, using heat, ice, other modalities, whatever it is, flotation tanks, whatever you have access to help manage your pain. And a big believer on the psychological aspect too. It's a power of the mind. So I'm a big believer. I had a major foot reconstruction a couple months ago, and my surgeon gave me a lot of narcotics and said that everyone takes narcotics. And I was like, I'm not going to. And he goes, no, you have to. And I said, I don't want a nerve block. And he said, okay, well, you have to do one or the other. And I said, I'm not going to have either. Because I can just mentally, I can tell myself I'm going to have 5 days of horrible pain, and then it's going to get better. So, and I think that, and I did it. And I think, not that I'm tough, but it's just it's going into it and knowing what to expect. So if you can talk to people beforehand and say, hey, look, it's going to be hard, it's going to be tough, but here's what your expectation is.
I think I find with a lot of kids going into surgery, they don't realize, and I used to do it, and I probably should be better at it. I know in the past, I've told kids prior to surgery, I said, you're going to feel like you got kicked in the shin by a horse. I mean, that's how bad it's going to feel. They're going to be drilling, into your tibia. It's not going to feel good. But you talked about like pain management, and one of the questions I have is kind of this steroid injections. There's more and more research about steroid injections, how it's deleterious to the tissue. There's even, reports of how trigger point dry needling is actually more effective than steroid injections. Is this, with the new research that's coming about, how's this going to change your practice?
Yeah, I agree. I've never been a fan of steroid injections. I mean, I've always been leery about the deleterious effects of it on the articular cartilage. And so it's kind of my last resort. I mean, somebody who's 75 years old and trying to delay a knee or not have a knee replacement, or, we can do a steroid injection on someone like that. That's fine. But even on a rotator cuff, Andrew, like somebody will have some, small rotator cuff tear or tendinopathy. And we always do steroid injections for people like that. But the problem again is it's detrimental to the tissue, and then the tear gets bigger, they need surgery, and then that tissue quality is poor. So that is something I really look at alternatives, and we talk about what other kind of care can we do. So looking at stem cells, looking at platelet-rich plasma, looking at hyaluronic acid, other options to manage pain as opposed to corticosteroid injections.
In my experience, it seems like you are in the minority in that thinking. I don't know, there are a lot of times when we run into, and I have the conversation when clients, I said, hey, you're going to an orthopedic surgeon. You're not going to an orthopedic doctor. They were trained to cut. Not all of them think that way, but, that is something that, how else can we educate the other doctors or get them out of this habit of relying upon either opioids or steroid injections?
Yeah, I think it's all education. I mean, I agree with you, Andrew. I see a lot of it. And I think that I try and educate the patients about it, because patients come in asking for it. I think I just really have been lucky. I've taken care of professional athletes, young professional athletes, right? So I'm always looking at the longevity of their career. And that's why I'm always trying to think of alternatives. Like, let's think outside the box, and they are managing, especially on the football side, managing pain every day. And so how do we manage it? And how do we keep in good control of it without doing something that's going to compromise them? So I think that's where it really started. And then I've kind of built my whole practice on that. But it's about educating the patients also, and educating other surgeons. And I try and, that's a topic I discuss a lot, actually.
With the, I saw a couple of years ago, or not a couple of years, I didn't see it, but I saw it on the website. You're on Outside the Lines, and they were talking about medical marijuana. Mm-hmm. Virginia now has medical marijuana. July 1st, recreational marijuana will now be legalized in the state. I know the NFL has their own rules, and I do believe they're trying to pass it, legalize it federally. I shouldn't say if, I think it's when they pass this, how will this come about? Because I know one of the things you spoke about on Outside the Lines is if you're doing an edible, you don't know exactly where the concentrated portion of the THC is in that edible. How to dosage and stuff. What kind of education is there out there now, with now that this is going to be an option? I know a lot of NFL players use marijuana to ease their pain.
Yeah, it is something, Andrew, that is not standardized right now, right? So you don't know how much THC is in it. You don't really know where the product's from. You don't know how clean and pure it is. So I actually don't prescribe it, because I don't really know what I'm prescribing. Like, I want to know the dose of something. I want to know its true effects, and I don't know where it's coming from. Is it laced with something? So I have a lot of concerns about it. I mean, I think it's a great option, and once there's some standardization around it, I'll be a believer in it. But yeah, it's a common, and players use it, and I'm not opposed to it. I just don't want to prescribe it until I know exactly what I'm using it for and what's in it.
And that's good. You're looking out for the patients, because like you said, the dosage is an issue. And I think even if it's passed federally to be legalized, I don't think the government has any plans of regulating it yet, as far as, they'll tax it.
That either. I agree. And I think there needs to be some regulation, so at least we know what we're doing.
Yeah,
the medication's regulated. We know what we're prescribing, right?
Yeah, correct. There are some injuries, back pain. I know your specialty is shoulders and knees. Oftentimes, back pain, it doesn't necessarily need surgery. Where are we now, where I know the research keeps changing on ACLs? Like, are there people that are not candidates or don't need to be candidates for surgery, how do you take that into effect? Or is the still, hey, you're going to lead to early onset arthritis, you need to have this done?
Yeah, Andrew, I'd say the majority of our patients are having their ACL reconstructed if they tear it. Now, we have younger patients who are active, and we know that there's a high likelihood of getting osteoarthritis if you don't reconstruct your knee and you have an unstable knee. There are all kinds of different kinds of ACL tears. You can have a partial thickness ACL tear that's pulled off the bone. But again, if I have somebody who's older and they like to walk and they have no instability with their simple activities, then maybe they don't need their reconstruction. But somebody who has any instability with activities of daily living, or they want to get back to cutting and pivoting sports, I recommend reconstructing their ACL.
Let's talk about the female athlete. So what are some of the things that cause female athletes to get or tear their ACLs more so than a male? And then I have another question, a follow-up question
Yeah, so there are modifiable risks and non-modifiable risks, right? So non-modifiable risks are risks that they're innately born with. So like anatomical things, they have it's called a tight notch where their ACL lies in their knee. That's a very narrow notch compared to men. They have ligamentous laxity, more ligamentous laxity than men do. They have an increased slope. The tibia, the lower leg bone, has a slope to it, and increased lateral tibial slope can lead to higher ACL tears. So they've got that. There are estrogen receptors on the ACL also. So throughout the menstrual cycle, it's going to change the laxity of the ACL. And so there are all these things that we can't change. I mean, that's how you are as a female. But there are also modifiable risk factors. And we know that when we look at girls biomechanically, there are a couple things. They have something called quadriceps dominance. Their quads are stronger than their hamstrings. And you see it a lot in soccer players. You look at your daughter, it's very common, right? And so that's where we see that these non-contact ACLs, because that quadriceps over-dominates the hamstring and leads to, it's called anterior tibial translation. It's a high stress on the ACL and it tears. They also have leg dominance. Typically, boys are not as leg dominant as girls are. Girls prefer one leg over the other. So that again you have a tendency to have some imbalance. And there's something called trunk dominance where they don't have a lot of core stability. So the inertia actually is not well controlled, right? So when they're running and they can't control their core as well. So all these things, those are all things that we can help. And these modifiable risk factors are what we focus on. So when you're treating a female athlete after an ACL tear and they're getting back to play, or as they're training to get ready for the season, you want to focus on those things and make them more symmetric, make their hamstring stronger, focus on their landing technique so they don't land with knock knees, which we typically see, right? More straight-legged. Typically, girls are going to land straight-legged and knock-kneed. Boys are going to land in a deeper squat and straight.
So if you got a female that it's on during her menstrual cycle, how does the coach be like, hey, how do you deal with that? I'm like, all right, I think you should sit out today because you're at a higher risk for an ACL tear.
It's interesting. I mean, it's a pre-ovulatory phase. It's actually not during their menstrual cycle per se, but there are a lot of studies out there looking at using birth control pills and things like that. And there are some studies that support it actually. I'm not a fan of it, and I don't have my daughters take them, and my daughters play sports, and I don't change anyway. They practice the same every day. So I don't make changes to it. I really focus more on the neuromuscular issues, more on that quad dominance, making sure that they're balanced well. And so focusing on those things that we can change and not kind of messing around with nature.
I find, I grew up around here and I've lived, I think, at least half my life in Loudoun County now, and it's uber competitive here. People don't tend to want to pay for prevention. The insurance companies don't want to pay for prevention. How do we change how can we get the insurance companies to change their minds, or will that ever happen? And I think, why can't we get more prevention done? People more likely around here will pay for performance more so than they would pay for prevention. But you and I both know that performance and prevention are identical.
Yeah. Yeah, I have fought this many times, and there are a lot of great ACL prevention programs out there, right? Like Sports Metrics and PEP and all these different ones, and they show a pretty significant reduction between 65 and 80% reduction in ACL tears. So Why don't we do it? Why doesn't insurance cover it? And why don't people want to do it? And it's not hard, it's like 20 minutes, 3 times a week. It's not like it's a lot of time, but I think that's for a lot of reasons. I think coaches don't want to focus. Like coaches want to practice and play, right? They don't understand the value in it. Kids, like you said, they want to do performance. They don't want to focus on prevention. So what I've kind of done when I talk to athletes, I try and say, incorporate it into the practice. And I'll talk to coaches and say, just incorporate this part into the practice, into the warm-ups, and if you're doing some conditioning and training, try to incorporate it in. So you kind of get best of both worlds. But again, it's tough, and insurance will not cover it. They would save a lot of money if they did.
They'd rather raise our rates than that's a whole nother conversation. They'd rather raise our rates than pay for prevention. I mean, they have done some measures where they require people to have physical therapy before they can have an MRI, or require them to have physical therapy before they have surgery, which I think is, being a physical therapist and seeing that I've been able to help, eliminate some people's surgeries and stuff like that. Why isn't that more commonplace? There's more restrictions on that, because that's also one of the things of increased costs have gone through the roof, where physicians own their own MRI centers, they own their own surgical centers.
Yeah, no, I agree. Sometimes that PT, that saying try PT before you get an MRI or whatever, it kind of makes me frustrated, because I've had patients where I'm like, they have a rotator cuff tear, they had a fall, they have pain, I need to MRI them, right? Then doing rehab for them, it's going to waste their sessions, because they have 20 sessions of PT or 30 or whatever they're going to have. So it makes me crazy. So then I'm on the phone calling insurance companies and saying, the guy has a rotator cuff tear, like, let's get the MRI. He's going to need surgery. He's going to need PT. And why are we doing it backwards? So in some aspects, but I agree, a lot of patients can avoid surgery with PT.
Yeah, that's one of the reasons why we stopped taking certain insurances, because I didn't want to deal with the restrictions that they placed, because they would give, if I had, for instance, my daughter who's 13 and likes, is an elite athlete, versus myself, if I went and tore my, I'm an active guy. If I tore my ACL, they'd give me and her, if I had, I do have United Healthcare, she has Cigna, they'd restrict us. They'd probably give us the same number of visits between the both of us. And we're at two different levels. They don't care, the 18 visits, that's it.
Right. It's crazy.
It's insane that insurance is dictating, they're dictating so much in the how long you can stay, how many visits you can get, what procedures you can have.
Yeah.
It's a complete battle. So I got a scenario for you. Well, you kind of answered part of it, as far as you work as, I have Seth, who worked for the Orioles as the sports psychologist for their pitching staff. You now have said that you were a consult hired by the team to work, but your primary person is the player. So you work for the Nationals now. We've got a guy, Steven Strasburg. A couple of years ago, the Nationals make it to the playoffs for the first time in franchise history as the Nationals. And they decide that they're going to sit Strasburg. What kind of role would you have played in that decision, and talking with the GM, Rizzo, as well as with the player, as such as Strasburg, who's an uber competitive person? Now, we all know the results went in our favor, or in the Nationals' favor. And, he was a dominant pitcher, and they won the World Series. I know you were part of the team when they did that, but were you around when they made the decision to sit him?
I wasn't actually. I started the year after that, but yeah, a lot goes into that, right? So when we have to always look at, again, the player's health and where are we in the season, and is a player at risk for injuring themselves more? So we have to look at not just that season, but the following seasons, right? And that's where a lot of discussion. It's all about communication, right? You're talking to the coach, you're talking to GM, you're working with the player and trying to figure out, again, from a safety standpoint. Now, is a player kind of going to pitch through some pain, but not, still performing well? That's a different story, right? But if there's a significant injury that they could make worse if they pitch, then that's where we have to have that discussion. And it's important to have good relationships with them. But yeah, obviously, and I try to meet with the manager and the GM as often as we can to talk about injuries and make sure we're all on the same page.
Gotcha. So talking about injuries, one guy that you kind of helped out, he just retired, Alex Smith from the NFL. Was that a good idea, bad idea for him? And then I want to discuss, the injury and that kind of stuff.
Yeah, I mean, that was his decision, obviously. And I think it was the right decision for him. He made that decision. We, as the team physicians and as his medical team and surgical team, we cleared him. We gave him clearance to play. So he was medically cleared to play. But it's his decision. And when you suffer an injury like that, right, life threatening, limb threatening, it's also a personal decision. So I think that a lot went into the decision to retire.
So take me back. He's on the field, lying there, horrific injury. Tell me what was going through your mind during that time frame. You're at the field, he's on the field, his legs facing a completely different direction. It's a compound fracture.
Yeah. So it's, we see a lot of injuries, right? So when we're on the football field, lots of bad injuries. And so you get out there, it's kind of like every other injury initially as you're going on the field. I don't always witness the exact mechanism because it's crowded down there. I've got some big linemen around me and trying to see around people. But so you get on the field and immediately it's a significant injury. I didn't know it was open. Compound means open. Didn't know it was open until we got back to X-ray. Once I cut his pants off and realized it was open. And luckily, we talk about a great team. I have great trauma orthopedic surgeons as partners, and called them and said, "Hey, listen, we have to go to the OR." So we went that night and got him there immediately and fixed him. And then the infection ensued a couple days later. Within about 2 days. The issue is when you have an injury like that, an open wound, right? The tibia sticks into the dirt on the field, high probability of infection, which is why the surgery was so emergent, which is why we basically took him from the field right straight to the operating room to get everything out, clean it out as much as possible. And so that was sort of where the story started. And then we were in the operating room every night, I think or every day for 8-9 days straight. And just washing his wound out and cleaning it. And so he had a long, long road.
I've seen pictures of it. They transplanted quad into his, I'm just amazed. Now, granted, he played with an ankle foot orthosis because he didn't really have a lot of plantar flexion, but he really didn't have much dorsiflexion either, right?
So he had full plantar, probably a good plantar flexion. He had no dorsiflexion.
Yeah, I got that the opposite. Yeah.
So luckily, again, the team of orthopedic surgeons, we had a great plastic surgeon. And so they had to really reconstruct the whole leg because by the time the infection's gone, there's no muscle, no soft tissue left. I mean, he has a bone sticking out. You can see it on ESPN E60, but, so the plastic surgeon, we always call him the wizard, he's the magician. So he came in and he transferred the vastus lateralis from the left thigh to the right calf or to the right shin. And then he moved one of them, the gastrocnemius on that same side. He flipped it around and covered the front of the shin. So it's all reconstructive. So it's not super functional in the sense that he doesn't have dorsiflexion. He can't raise his foot up, which is why he has to wear that brace.
How much involvement did you have or talking with Alex throughout the whole process? I mean, it was 2 years before he returned to the field. How much involvement did you have once everything was healed or when he went down to Texas?
Yeah, a lot early on. So one of my friends is a physical therapist at the Center for the Intrepid. And so Johnny Owens. And so I called him early on in the first couple of days. I talked to Elizabeth, Alex's wife, and said, do you mind if I call my friend Johnny? Because I think Johnny at some point is going to need to help Alex, whether Alex has a limb salvage or he has an amputation. This is what Johnny does. He deals with all these warriors. So she said, yeah, certainly reach out to him. So I reached out to Johnny and said, Johnny, one way or another, I'm going to need your services. In a couple months, we'll know which way we're going to go, but I'm going to need your help. And he said, great. He said, bring him down whenever you're ready. So Alex got out of the hospital. He's there for almost a month and got out in December. And we talked to Alex and said, Alex, I think it's worth going and just going there and just to talk to Johnny, see what you can do. And people like you, see people who have an injury like yours. It's basically a blast wound at this point, and see what your life's going to hold for you. And I did it more, I think, for the mental reason. I talked to Elizabeth. I said, I just want him to go because he was in a bad place. And I wanted him to go to kind of just be re-energized. So we walk in there, and it was so interesting. All these, these people have horrible injuries, right? And they're all trying to get back to fight. I mean, they want to go and they want to do their job. And you see these amputees walking around, you see these limb salvage patients. They're incredible people, and they come running up to Alex like, oh my God, you're Alex Smith. And it was so interesting because they were all rejuvenated, but Alex is like, why are they looking at me? And then you start watching them, and you start watching him, and they're talking to him, and you're like, hey, I do this. And he's asking them about, hey, my leg looks so ugly, I can't even look at it. And they're like, dude, when you can finally do everything, when you're back playing football and your leg looks like, you're not even going to care. Like, if that thing's working, you're going to be proud of it. You're going to show it off. And I remember him thinking, like, really? Like, at this point, he was still so traumatized by the experience, right? But it was that day that Johnny Owens put this football in his hand, and Alex, all of a sudden, his whole face lit up, and we walked out of the parking lot. And that night, he said to me, so when are you going to clear me to play football? That was the first time that he said it. He had not even, hadn't even mentioned it until that day. So, that's what our goal was, right? To kind of, again, just to give him a goal. Everyone needs a goal, right? I mean, you see it, Andrew, with everybody. Any person who has an injury, you need to have something that you're looking forward to. What is it, whether it's gardening, playing with your grandkids, or getting back to the football field.
Yeah, I mean, my clinic is called Performance Physical Therapy, but performance is pretty generic. I mean, you want to perform what? It doesn't necessarily mean perform on the field. We find it oftentimes that there's got to be an internal driver, because, like you said, Alex was super depressed, that there was something missing internally. Now, how do you deal with some of these athletes that can no longer, hey, this is career ending? I mean, that was a career ending injury. Not everyone can return to the field after that. How do you help them? I mean, you seem to be very involved. I mean, that's awesome how caring and supportive you were of Alex. But how do you deal with that athlete that says, all right, you've got a total knee disarticulation, and you're 34. I don't think, you're going to be playing football again as a running back. Yeah. How do you get them to that next stage of life?
Yeah, I always try and think about that too, again, and I think having this whole team of people is so important, Andrew, because they're the ones I rely on. I mean, again, I'm an orthopedic surgeon, and I try and support them as I can, but we work with sports psychologists and physical therapists, and trying to introduce them to other people like themselves, right? And say, you've got more to life than just this. Let's see what else we can do. It's certainly tough. And a lot of these kids grew up, this was their dream, right? To play in the NFL, and now all of a sudden their career has ended. And what are they going to do? A lot of them maybe didn't finish college and don't have the necessary education, right? So I talked to a lot of the athletes about that. I mean, even the healthy ones will say to me, hey, I'm raising my kids to tell them, like, go to college and get your education and finish that, because I never did. And I didn't really care about school. I always wanted to play in the NFL, but there's so much more, because now I just had a player a couple of days ago come into my office, and he said, like, I'm probably going to be retiring in a year, but now I don't have anything. I'm going to be 30 years old. I don't have much else. Like, what else am I going to do? So he said, I have my 9-year-old kid, and I'm trying to teach him. Like, there's a lot. You take advantage of this now. Take advantage of your education, because there's so much that you can get out of it. And he said to me, because education's a gift, and I never realized it. So I think that's what we, again, trying to say there's so much more that you can do.
So last question. I know you're super busy. How do we get more girls involved and interested in sports medicine? I have a daughter, she comes to the clinic. I'm like, hey, you're going to help, you're be a PT one day. And no, I don't want to do that. I'm like, come on, man. We have this
whole. I see her, Andrew. She's a good helper down there. I see the pictures.
She, she every now and again, she'll help out. She likes working with the young kids. It's very helpful to have her in there when the younger kids are injured, that she likes to be able to help out and motivate them. But how do we get more girls involved in orthopedic surgery and sports medicine?
Yeah, I think by showing them that it's possible, I think it's just exposure. I think people don't even know. I mean, even when I was going to orthopedic surgery, I remember, I trained a long time ago. So, but I remember even interviewing and guys saying, well, you're not strong enough, or you're like, what are you going to do when you get married? I'm like, I'm going to be an orthopedic surgeon. What are you going to do when you have kids? I'm like, going to be an orthopedic surgeon. So I think that people that don't really even think about it, and I get a lot of questions from high school and collegiate athlete or girls who say, what do you have to sacrifice to do if we want to be like you and be an orthopedic surgeon? And there's always sacrifices, right, Andrew? Whatever you do, I mean, you have to figure out, there's a balance on how do you do it. It's never going to be perfectly balanced. I always tell people it's going to wax and wane, right? I mean, if something's going on with my family, if my daughter needs me or something, that's taking priority. If one of my patients needs it, that's going to take priority. So it's always a shift, and it's never fully balanced. Things are going to have to suffer one way or another. But I think that exposure is key, and showing people that it's possible.
How many hours a night do you sleep?
Well, I need more sleep now that I'm older. I used to not, but so I am an early riser.
That's you got, I can't imagine with, when you are healthy to have time to train, plus, running around with now, where it was, you have a little extra time not having to deal with, Washington.
Yeah.
But what are you going to do with that extra time? You said, I know you said it's, hang out with your daughters, but there's got to be something like, missing on that sideline. I understand we spoke earlier. You said, I'm going to go to tailgates and stuff, but after 18 years, I know I had a hard time when I had to stop playing football. I got to college to sit in the stands and watch, knowing that I could still be out there.
Yeah, no, it is tough, Andrew. I've got some other good opportunities that I'm pursuing. And so my husband's always like, you never are not going to be busy. So I have some interesting things. And again, I'm the president of the musculoskeletal service line for Inova. So I oversee there are over 200 orthopedic surgeons and all the physical therapists, inpatient, outpatient, the physical medicine and rehabilitation physicians, podiatry. So I've got a big group of people that we're trying to build this service line and really provide the top-notch care to our patients. So helping to make these care pathways across the system and really unite everyone is a big job. So I'm going to focus on that.
I don't know if I've read this right or not. You guys are building a comprehensive care campus, Yeah,
we are in Springfield. Actually, it's going to be a hospital and a physician office building and an ambulatory surgery center. And it's going to be very MSK focused, meaning musculoskeletal orthopedic focused. So probably 7 years away, but we're in the planning process now.
Okay, good. So as long as Eden's, still playing sports, we can get in touch with you out here in Ashburn. And
she'll be working there probably. But
well, I really, really, really appreciate you coming on. Thank you so much. I'm sure at some other time we might want to have you back on. You're so knowledgeable. You're an expert in the field of sports medicine, and I appreciate what you've done for my daughter. And thank you so much.
Well, thank you, Andrew. Thank you for your great care of our patients. Yeah.
You're welcome. It's my passion.
I can tell. Thank you.
Thanks.